Good morning to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Shashikala Prabhakaran. Ma'am is MBBS, DMRT, DNBRT consultant at the Department of Radiation Oncology at Healthcare Global, HCG, Bangalore. With the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is role of radiation in CNS tumor. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her. Over to you, ma'am.
Yeah, thank you so much for giving me an opportunity to talk about the role of radiation CNS tumor on the World Brain Tumor Day occasion. So I'll be just talking in another 20 minutes about the role of radiation in the brain tumors, both benign and malignant conditions. So always we believe, especially in oncology, prevention is better because we don't talk about cure in oncology because we have seen people with stage 1 coming back with recurrence, and we have seen people with stage 3 or 4 living for a long time without any problem. So that is unpredictable in cancer, so it's always prevention. So when we see the people who come with brain tumor, even though the brain tumor are caused because of the mutation in the gene, but when we take history, we are seeing young people like from 20 to 30 years getting with glioblastoma multiforme, high grade glioma. And when we take the history, recently one of the patient, he was using mobile all the time, playing games, and the screen time daily is more than 6 to 7 hours, like that. And maybe that could be the triggering factor uh, for the brain tumor, and there are some studies which prove that also. And again, inadequate sleep or excess stress, and again whatever, it's a multifactorial, not only the genetic mutation, but whatever the environmental pollution and what we take in the food, chemicals, everything together is a cause. So before going to role of radiation in brain tumor, I just want to give a bird's eye view of the radiation machines, how we evolved from 1951 to till now. And we started with the cobalt machine, where we use a radioactive isotope cobalt for treating the patient. And then we moved on to non-radioactive treatment like high energy X-rays. So we use mega voltage energy range of X-ray to treat the cancer. And again, if you see the gamma knife, this is mainly used for stereotactic radiosurgery. Again, here the uh, radiation beam comes from about 206 cobalt radioactive isotopes are within the machine. So we have variety of machines, and now we have proton therapy, and this proton is available only in India in one center, that is in Chennai, Apollo. So that proton therapy really plays a major role in CNS tumor. Because the precision of delivery of the radiation and the normal tissue sparing is much more better in proton compared to our regular X-ray, regular linear accelerator based treatment. So again, as gamma knife, we have a cyber knife machine, and this also use a high energy X-ray to treat the brain tumors. Especially the cyber knife, gamma knife, and the protons are used for stereotactic radiosurgery and stereotactic radiotherapy. So just brief about what is radiosurgery and what is regular radiotherapy. So radiosurgery is, we deliver a high dose per day, and we finish the treatment either in a single day, or we finish within 5 days of the treatment. That is called radiosurgery. Whereas in regular radiotherapy, we use very low dose per day, and we protract the treatment for 30 days. So that's how the radiosurgery is very sophisticated, and it is very it's a non-invasive treatment, and the treatment time is, overall treatment time is very short. So if you talk about precision of delivery, radiosurgery, there is a millimeter accuracy in delivering the treatment, and it is very precise, and it ablate only the tumor, and the normal tissue is completely spared. So these are all the other types of the machine where we use for stereotactic radiosurgery and radiotherapy. So how this radiation acts in the tumor cells, usually it will cause a DNA damage and there will be a complete cell kill. That too, when we deliver a high dose per fraction, that is per day, then the cell kill is enormous and it will inhibit everything, the genetic expression, protein expression, and it inhibit the fibroblast formation, so that the cancer cells are killed immediately. Whereas if we treat with our regular radiotherapy, it takes some time for the tumor cell kill because the dose is less and the tumor repair happens and the repopulation occurs. Whereas in high dose, those things will not be there and there is a very good tumor kill. So I'll be talking in further slides about the benign conditions where we use stereotactic radiosurgery in brain. So meningioma, usually meningioma grade 1, there is no role of radiation. Just a simple surgery is enough. Whereas if we go to meningioma of grade 2 and grade 3, uh, again, even though the surgery is complete, it is always better to give radiation after surgery because the grade 2 and grade 3 meningioma is highly likely to come back in the same place. Recurrence are high in grade 2 and grade 3. Grade 1, when you will treat only if it is a subtotal resection was done, or if it is a recurrent tumor, then there is a role for radiotherapy. So coming to the dose, so if it is a grade 1, our dose is very less, 50 to 54 gray, whereas in grade 2 and grade 3, the dose is little high, 63 gray. So this is when we treat with regular fractionation, that is daily for 30 days. Whereas if we go for a stereotactic radiosurgery, our dose is anywhere between 12 to 16 gray. So again, one more benign condition, that is a pituitary adenoma. So this is a commonly seen case. In our clinic, we see more pituitary adenoma, and usually they get surgery done, and most of the time surgery may not be technically possible to remove the complete tumor. So in that case, after the subtotal resection, we always follow it with radiation because again, the recurrences are very high in pituitary adenoma. So again, our dose differs between the non-functional tumor versus functional tumor. So if it is a non-secretory hormonal pituitary adenoma, the dose we stop at 50 gray, whereas if it is a secretory pituitary adenoma, we go a little higher up to 54 gray. So again, one more benign condition, cystic pharyngioma, craniopharyngioma. So in this, there is a cystic embryonic malformation in the cellular or the paracellular region. So it extends locally into the hypothalamus, optic chiasma, cranial nerve, and third ventricle. And usually, any brain tumors, they always present with headache, nausea, vomiting, the typical projectile vomiting, early morning headache and vomiting, and visual disturbances. Another, since it is in cellular region, endocrine disturbance also happen. And again here, always a safe resection and then followed by radiotherapy up to 54 gray. So again, coming to acoustic neuroma. So this is quite often we see, and in this acoustic neuroma, usually we don't prefer surgery because it is arising from the nerve. So it is always better to treat directly with radiation, and usually we do stereotactic radiosurgery, and the local control is really good. So acoustic neuroma, usually we treat with radiation instead of surgery. So coming to chordoma, chordoma is again a slow-growing midline tumor. These chordomas occur in the base of the skull, and again in chordoma, really the proton therapy really benefit, and we can escalate the dose with proton therapy with 65 gray or more than that, so that we will have a good local control. And again, one more benign condition, that is arteriovenous malformation. This AV malformation, again, we can treat with radiation if surgery was not possible because it's a highly vascular lesion, and usually embolization they do and then do surgery. But whenever the surgery is not possible, then we can treat with the radiation. Again, the dose depends upon the size of the lesion, and it will go anywhere between 16 to 24 gray if we are treating with single fraction. And it depends how many fractions. Maximum we can treat up to 3 to 4 fractions. So depending on number of fractions, the dose depends. And one more benign condition, this is trigeminal neuralgia. Again, in trigeminal neuralgia, uh, if the surgery is not possible, then always we have treated quite a number of patients with radiation, and they really had a good pain relief, and they present with severe facial pain, intolerable facial pain, and we treat only with a single dose, that is just a single day treatment, and we try to give almost 70 gray. Only the problem is the brainstem will be very close by. So brainstem is the normal structure which we really take into consideration when we are planning for the trigeminal neuralgia. So coming to gliomas, before going to gliomas, usually the patients with glioma present with headache, and if it is a frontal region, they present with seizure, and if it is a cerebellar region, they will be having imbalance in gait. So depending upon the location of the tumor, the symptoms will be there. So before going to the treatment of glioma, now we follow the latest molecular classification of glioma. So this is IDH. There are two types. One is the IDH get muted, and another is the IDH is wild type, that is not mutated. So if the IDH is mutated, then we look into ATRX mutation. If there is no ATRX mutation or no TP53 mutation, and if the patient have 1p bar 19 co-deletion, so this 1p bar 19 co-deletion is very important. And if this mutation is present, then there is a good prognosis. The outcome is really good, and they do well with surgery followed by radiation. So we call it as oligodendroglioma. But if there is a ATRX loss or mutation or P53 mutation, and if they don't have this co-deletion, then again they are subdivided whether they have the CDKN2A mutant or non-mutant. If it is a wild type, that is non-mutant, they go into the classification of astrocytoma, that is IDH mutant, but with grade 2 or grade 3. If they have this, apart from this ATRX loss and P53 mutation, any patients having this ATRX loss or P53 mutation, they go into high grade, that is grade 4, with CDK2A positive. Almost same like this. Grade 4 is the glioblastoma, and the same, almost same like this for pediatric also. So usually low-grade glioma usually go for surgery first, and if the surgery is complete without any residue, then we usually don't give radiation. But there are certain indications even in low-grade glioma when we give radiation. That is, one is in a recurrent setting, or if there is a subtotal resection was done, or if the tumor is very big, like more than 6 centimeter crossing the midline, and these are all the indications for giving radiation after surgery in low-grade glioma. Coming to high-grade glioma, it is a part of the radiation is part of the treatment, and usually high-grade glioma, sometimes it's not possible to remove the tumor. They come only with a biopsy, and then we give radiation for high-grade glioma. High-grade glioma, usually they are called as anaplastic astrocytoma grade 3 and glioblastoma multiforme grade 4. So this is a pictorial representation. We do a MRI and fuse with the CT scan, and we mark the area where exactly we need the dose. So if you see this red outline, this is the postoperative cavity which we include in the radiation. And from there, again, we give a margin of 1.5 centimeter, where we cover all the edema region, because we think does edema also have microscopic tumor cells. And from, so whatever the red you see, we call it as clinical, or we can call it as gross tumor volume. Actually here there is no gross tumor, it is removed by surgery. So it is the cavity which we mark. From there, we give a 1.5 centimeter margin, and that is called the clinical target volume. And so up to this blue is our treatment target. So whatever the prescribed dose, we give 50 gray or 54 gray. We make sure this whole region receives this radiation. And the yellow is the planning target volume. This margin we give for positional error, we will give. So you can see the edema is included in the part of the treatment. So this is how we plan the radiation. We do MRI and CT, and then we fuse it. And now there are latest technology have come, like we do a PET, which is specific for brain tumors, like methionine PET or choline PET, and then dopa PET. All those things we do, and so that we can target the tumor in a better way. So this is the slide which whatever I explained the margins about how we plan the radiation. And so actually my take home message, what I want everybody to take home is, there is really a major role of radiation in brain tumors. The two, all gliomas has to be followed with adjuvant radiation if it is a high grade 3 and grade 4. Mandatory grade 3, grade 4 glioma has to undergo radiation, whereas in grade 1 and grade 2, only in specific indications we give radiation. And there is a major role of stereotactic radiosurgery in benign conditions also. So it's not only for malignant, also for benign condition. And now with the advent of latest PET scan, we can differentiate recurrence or the radionecrosis with this dopa PET. And now again, even recurrence come if surgery is not possible, with the latest technology, with the cyberknife or with proton, we always have a chance of giving second time or third time radiation to the patient without any side effect. So these are all the highlighted points I really want everybody to know. So that's how I just shared the bird's eye view of the role of radiation in brain tumors. So any questions, we can have an interaction. Yeah, thank you.
Thank you, ma'am, for your wonderful presentation. So, ma'am, we are still waiting for some questions to come. So, meanwhile, ma'am,
Okay.
any take home message before we got the question?
Yeah, actually, like that's what in brain tumor always now the new imaging have come, like a PET scan and MRI, which is very precise in diagnosing the disease. And then we have a lot of radiation techniques we have, like say like IMRT, IGRT, SRS, SBRT, like that. A lot of techniques of higher end technology have come in radiation delivery, so that there won't be any side effect with the radiation. And again, even recurrent lesions, now there is an option of re-radiation. We can give second time, third time radiation without any normal tissue toxicity. And again, there are a lot of systemic treatment also. Chemotherapy also plays a major role in CNS tumor. So if we talk about glioma, the major drug, the chemotherapeutic agent we use is temozolomide. So it is a tablet form which the patient take along with radiation to increase the effect of the radiation. We call it as radiosensitizer. And again, there are multiple chemotherapeutic regimens which is available to treat brain tumors, like a PCV regimen. And bevacizumab is a targeted agent which we can use along with radiation, like SRS or SPRT, to have a good effect, because it is a anti-neogenesis, and it prevents the new blood vessel formation, this bevacizumab drug. So like that, in CNS tumors, all three plays a major role, like surgery, radiation, and chemotherapy. So it is a multimodality approach which will give a good outcome to the patient. Yeah.
Ma'am, thank you. And we do have some questions now. So, ma'am, the
Yes.
first question is, how do you approach discussing the potential benefits and risk of radiation therapy with patients and their families?
No, that's what. See, what we say is, if at all the patient say I don't want radiation, then we will explain about, if the patient don't have radiation, what are all the sequelae they come across. Say if it is a grade 3 or a grade 4 tumor where surgery was not possible, only biopsy was done. If the patient didn't get radiation treatment, then the tumor keeps growing, and there will be multiple, there will be edema, there will be a huge edema in the brain, and the patient may go for increased intracranial pressure, and patient may go for coma, all those complications. So we try to explain to them how important the radiation is. And people really get scared. Radiation means it's like current, they call it as in a, local language like current, and they really get scared. It's nothing like that. We have now higher end machine and higher imaging technology where we precisely treat that, and there won't be any side effects. As such, we have not seen any major side effects so far with radiation. Yeah.
Ma'am, the next question is, can you present a challenging case where radiation therapy play a crucial role in the treatment plan and discuss the outcomes?
Particularly in a CNS tumor, right?
Yes, ma'am, that's right.
Okay. So I can challenging case means I can tell, we have treated a carcinoma lung patient upfront presented with brain metastasis. Patient had a single lesion in the brain, and we have given radio surgery to that area, and then the patient received chemotherapy, and again patient developed one more lesion in the brain. Again we have given SRS, stereotactic radiosurgery. Again patient was on chemotherapy, and again patient developed a lesion in cauda equina region, and then again we given. Actually for that patient, even though patient presented with CA lung with brain metastasis as a stage 4 disease, she lived for more than 7 years, and she received radiosurgery at least for 4 times, and the quality of life till the patient died was very good. So that's one of the challenging case, which we thought it will be patient may not survive, but patient survived for more than 7 years. And then one more, we have treated 32-year-old man with a grade 3 astrocytoma, and then we have given our regular radiation like for 5 weeks, and then we have given boost to that cavity, where they have this neurosurgeon has not removed the tumor completely, and then we boosted that the gross disease with the radiosurgery cybernetic we used, and now almost 2 year 1.5 years follow-up, patient is really doing good. So these are all the cases where and again I have treated optic nerve glioma, optic chiasma glioma. See, if the tumor comes in the optic chiasma, the vision will be always, see, even though we give the dose up to the tolerance of 54 gray, they may get some late effect because of the radiation. And I have treated this patient, must be 10 years back, and the patient had vision loss in the one eye, but one eye there was little vision, and actually the as such the patient was doing good almost for 10 years. So these are all the challenging cases I remember which I have treated. Yeah.
Thank you, ma'am. The next question is, what role does immunotherapy play in combination with radiation therapy for CNS tumor?
Mm. As such, see, immunotherapy was playing major role in all other sites like lung. It is now first line now immunotherapy, and metastatic all other like cervix, breast, and all immunotherapy is there. But for CNS tumor, it is still in trial basis. It has not come still as a standard of care immunotherapy in CNS tumors along with radiation. But we have in liver and other areas where we give radiosurgery, this immunotherapy really acts like a radiosensitizer. So we use immunotherapy with radiation in other sites, but not in CNS tumors.
The next question is, ma'am, how does the long-term impact of radiation therapy differ between pediatric and adult patients?
Yeah, it's a good question. So the thing is, pediatric, it is a developing brain, okay? And so in pediatric, usually we don't use like techniques like IMRT, all those things where our integral dose is high and the patient may have late effect. So in pediatric brain tumors, we prefer mainly proton therapy because there is a sharp dose fall off from the tumor to the normal tissue and there won't be much late side effects. So in pediatric tumor, the preferred treatment is proton therapy, not a regular cyber knife or other treatment, but it's not available in all the centers. So what we do is in pediatric mainly we use very lower end technique like 3D CRT, what we call, where we control the integral dose so that there won't be any long term side effects with radiation. So it depends on which area we treat in pediatric. So pediatric rarely we treat. We are not much experience in pediatric tumors, but we have seen quite brainstem gliomas come in pediatric. Usually, as such, the glioma, the survival rate is very poor, and they live to get the radiation side effect. They have to live for more than 5 years to have the side effects. So that is less likely in glioma and pediatric. Yeah.
Thank you, ma'am. There is one last question. What are the
Yeah.
key factors that influence the prognosis of patient undergoing radiation therapy for CNS tumor?
See, the key factor, see, one is maximum safe resection. In any CNS tumor, the best surgery is the first predict the good outcome, wherever possible, the maximum safe resection or complete resection of the tumor, the outcome is good. So in that case, we give adjuvant radiation, it have a good effect. Whereas if we treat a patient where the surgeon has left some tumor, whether technically it is not possible to remove completely, the outcome or little poor compared to whoever had done a complete surgery. Yeah, that's a major key factor in CNS tumor, the maximum safe complete resection of the tumor.
Thank you so much, ma'am, for answering all our questions. And that's all for
Yeah.
today's session. And thank
Yeah,
you
thank you.
so much, ma'am, for joining us today.